Um, so thank you very much for the kind introduction. It's my great pleasure to present in the epi department where I have many friends and colleagues. So as many of you know, I have worked on EHR data primarily as a focus on my research in recent years. And for, oops, sorry. So for those who are not so familiar with EHR data, I'll first give you a little bit background. There has been, in the US particularly, but worldwide, I would say, there has been a steady increase in the adoption of EHR data, even though initially it's mainly driven by the need of improving patient care. It has become a rich data resource for many of us. And part of the reason it is so valuable is that it really records rich information on a wide range of diseases. It has detailed longitudinal data that we can see, for example, the progression of the disease over time. And it also enables us to perform large-scale studies, particularly for rare conditions, because if you actually recruit patients to your study for a rare condition, it actually takes a long time. But patients are already in the EHR system. So if you can identify them, then, for example, recontact them, then it becomes much, much more efficient. Many of the institutions, including our own Mass General Brigham, that links biobank to the EHR data, in which case now not only we have rich phenotype information that, for example, includes disease conditions, medication, procedures, it also encode clinical concepts that we can extract from narrative text. So generally speaking, you can separate EHR data from the phenomic side into codified and free text data. But with biobank now integrated, and not for at least a fraction of the patient in the EHR, we also have the genomic information that we can extract. And I would say more broadly available genomic information will be some kind of variant information. At least, for example, for the GWAS kind of chip-based, but in recent years, there has also been much more increase in exome sequencing or whole genome sequencing. So a few years ago, when I started working with VA together with my long-term collaborator, Catherine Liao, who is a rheumatologist, but has been working together with me on a wide range of informatics-driven projects, which includes this particular one, where we did more like a proof of concept. If you take a particular genetic variant, and this variant regulates a protein, and basically it's a functional variant, and there are also drugs that developed to target the protein. For example, in this case, L6R variant correspond to the drug of tocilizumab, which is an approved drug for treating rheumatoid arthritis. So we were interested in understanding whether the genetic variant can be linked to a wider range of disease phenotypes to understand the potential effects of the drug that will tell us secondary basic alternative indications of the drug for drug repurposing. It can also potentially detect side effects. So in this study, at the time, VA has about 350,000 veterans genotyped, and we were able to identify signals related to cardiovascular, basically protective effect of cardiovascular traits for tocilizumab. And that agrees with much of the literature in recent years to understand what alternative indication tocilizumab can have. It also, interestingly, was able to identify side effect of the drug, which is actually skin irritation, which was also reported as a side effect of the drug. Because EHR data encodes, things change over time. So the longitudinal nature of the EHR data also provides a way for us to derive clinical decision support tools. Basically, if you put patient at a particular time point and look at things have been happening to the patient prior and up to this point, we can predict what might happen to the patient in the future. So basically, by rewinding the time, we can actually use EHR data to develop early detection tools. Currently, we have an ongoing two projects both are funded by Merck. One is looking at early detection of lung cancer, which we work closely with David Khoshrani, also at the school. And we were interested in looking at EHR features at any given basic moment. And we want to see, can we actually figure out whether this patient is at high risk of lung cancer, and we can recommend them for cancer screening. So even though currently there is cancer screening rules and strategy recommendations in place for lung cancer, it's actually not implemented so well. We also don't have very detailed smoking information, for example, in the EHR. I think in recent years, it's a little better. At least we would record smoker, non-smoker, current, past, but we don't still have routine collection of pack years, for example, which would disable us to really implement the screening rule sort of based on the data alone. And we're hoping to see whether using the algorithm that we develop, we can basically use the not so detailed EHR data, but devise tools for us to identify such patient, and maybe we can recommend these patients to be screened for lung cancer. We also have a close collaboration with Jordan Smoller's group. Jordan is one of the, I believe, also joined appointment at the Epi department. He's I believe, also a graduate from your department. And we are collaborating in developing.
Yeah.
Yes. So he's, of course, now very well known, and we are working on an NIH-funded grant to look at suicide risk prevention. So basically, we try to use the EHR data to look at all features that we see in the EHR data and predict who's at high risk of suicide ideation. And depending on the clinical setting, for example, the primary care setting, these are outpatient data. We look at their record and say, can we identify patients who are at much higher risk compared to the general population? And we look at, in a different scenario, patient already went to emergency department, psych emergency department, and these patients already have elevated risk. Typically, they have depression or some other psychiatric disorders. And we also predict risk and flag patients potentially have high risk. And the other category will be psych inpatient. They're already hospitalized. So these patients, their base risk is very high. And we're trying to decide what to do. I would say the most interesting piece to me personally is the translation piece. Jordan is assembling a team together also with Matt Nog, who's a co-PI of the project with Jordan. They're trying to actually run randomized clinical trial now, taking these risk prediction from these algorithms and randomize patient. And it's actually randomized, not just patient, also the treating physician, to give them the score and then decide what to do with the patient. Recently, we also had a very interesting collaboration with FDA through a commercial entity that they contract. And the FDA at that point, it was about 2 years ago, they had a planned congressional hearing for a particular medical device. There is some potential signal of elevated risk for this outcome called type 3 endoleak. And the device itself is for it's an EVAR, we call it EVAR, endovascular aneurysm repair. So the device itself, actually the first few iterations of this particular device from this company had already been recalled. They had much higher adverse event. So after multiple iterations, the current one in the market, they were hoping that it's effective and at least comparable side effect, but they had some kind of warning. So they were worried that it really had higher risk, and they had to decide, should they pull the device off the market? So this is, I would say, the most intensive analysis period I've ever had in my whole career. I felt like a slave for the FDA, but it's also fascinating to me because this is when we can actually leverage EHR data to do a real-time analysis of the data to see is there any safety concern. This is fascinating to me also. In this figure, we recently got published in JAMA Internal Medicine. I jointly run the study with Florence, who's the head of co-director of the Harvard MIT Regulatory Science, which is now sitting within medical school. So we took the data from VA, who kindly agreed to collaborate with us. And it's really a very challenging study to do because the devices are actually not very well coded. We had to look for model numbers that are all text. So we have to figure out which patient is on what device from the model numbers in like nurse notes, surgery notes. Also, the outcome of interest here is called type 3 endoleak. So that is definitely not coded. It's in the notes. And also, there's a huge amount of negation because FDA already has several warnings about existing device. So physicians start like tracking whether this is, an issue for the particular patient. So there's a huge amount of negation. In fact, I believe it's like, 70 or 80% of the mentions are negations. So when you run NLP, you definitely have to pay attention to that. And we basically use our NLP tool to extract the type 3 endoleak, which we fortunately were able to achieve very high PPV. We ran the study, but we have to be also careful. It's a causal modeling, right? We're comparing to a traditionally used device, and we wanted to know whether the device, this particular AFEX 2 is the one in red curve on the left. The left figure shows you basically the event rate from different adjusted event rate after we already did causal modeling. So the black curve to the bottom is the traditional ones, and the red one is the one under investigation. And the two on the top, you can see they obviously had higher risk. Those were already pulled off market. So that's why they were pulled, because they definitely had higher risk. But the red one is also fascinating because we unfortunately at that point of analysis, we only had maximum about 5 years of follow-up because the device were only in the market for about 5 years. So right now, I would say as a statistician and as someone who really work on, EHR for real-time monitoring, I'm very interested in going back to the data and see whether now 7 years into the follow-up, whether the signal is increasing. So again, go back, if you look at year 4 and year 5, there's actually a big bump. And but I wouldn't say unfortunately, the p-value is not significant. So in other words, you cannot for sure say it has an elevated risk. So the FDA's recommendation was actually to say that they basically asked them to wait and see. The one on the right-hand side is mortality. So from mortality perspective, fortunately, the new device and the traditional non-effects device, they are actually very comparable. Again, but if you look at the older devices, they do also have higher. So basically, the conclusion is that the older devices definitely were worse. The new one that's under investigation, we don't know yet. We probably are certain that the mortality, they're probably fairly reasonably comparable, but for type 3 endoleak, we do hope to go back to the data and refresh it. So these all show us the potential of EHR data for translational research. But if we really want to leverage EHR data for so-called real-world evidence, the real-world evidence doesn't have to be just on causal effects. Could be, risk predictive modeling, etc. It has many challenges because they rarely represent real-world scenario, real-world patient, real-world health system. So it's very susceptible to bias. One, of course, confounding bias, as we can see even in the device study. There's health system bias. If you look at the VA patient, for example, even though they cover about 17 million patients, they tend to be much sicker. They tend to basically have a lot more comorbidities. They were all veterans, so they have other characteristics, and also the vast majority of the veterans are male. So you can see, obviously, if you use that only to draw conclusions, I'll be a little bit more cautious because what happened to the female participants. So also there's data quality issues. During pandemic, we actually work with many institutions using their EHR data, but not sharing the data, of course. If you learn with multi-institutional data, there's privacy concern. We cannot take their patient level data. So we can at most ask them to share summary level data with us. As I mentioned, there's heterogeneity in patient population, but there's also heterogeneity in the coding system. So even between VA, Mass General Brigham, and University of Pittsburgh Medical Center, which I also have a close collaborator, these three health systems all have their unique coding aspects for both medication and labs, for example. That makes the analysis, joint analysis, highly challenging. But there are different methodologies that we have developed over the years trying to overcome some of these challenges. Today, I'll touch upon two specific aspects. How can we achieve so-called robust federated learning? Federated learning in the sense that we only require sites to share summary level data here, but robust is robust against several aspects I will touch upon later. Essentially, whether the model fits well to the data, whether they have data quality, etc. And towards the end, I will also highlight some of the methodologies that we worked on that aim to achieve automated data harmonization. But I also will show you that through this step, what we derive from our representation learning, which is the algorithm behind that, give us a lot more than just achieving data harmonization. So I want to put us into a particular context. I think Miguel actually has several very high impact, super well-written paper also based on the VA data. For example, I think he has a very nice New England Journal paper looking at the COVID vaccine comparisons across the VA system. But can we actually compare the COVID vaccine using data from more than one health system, so that we can be more robust in terms of the interpretation of the results? Can we co-train, for example, prediction models to improve the generalizability? And again, in the end, how can we harmonize the data to do co-training? So I'll first talk about federated learning of causal treatment effect in the context of estimating, comparing COVID vaccines. When we have multiple institutions and we want to look at, for example, COVID vaccine effect, you can say, I am interested in a particular target population. You can specify your target population. It could be target population just being one of the sites, for example, or the target population could be, pull all the data, like everybody on average, that's your target population. But you can select for the simplicity, let's imagine the target population being, each of the site at a time. But under the real world data, there are many constraints that we have to work around. There's bias issue due to confounding, as I mentioned. And of course, if we can impose statistical models to address all these confounding, it's a very easy task. But the reason this is so hard is because there's also potential model misspecification. I wouldn't jump this into any more detail because I know in the audience, there are many experts in this area. There's also heterogeneity due to different treatment guidelines. So in other words, if which health system receive, like which kind of patient receive what kind of treatment, if we go beyond vaccine, actually highly dependent on the health system. So in that case, basically the propensity score that we model could be very, very different across health system. I would never assume that they are shared across system. But how the outcomes how the confounders affect the outcome, I'll feel more comfortable that at least, many of them, they do share the outcome model. And we have privacy constraints, and we do have to worry about communication cost. So during the COVID pandemic, I actually work together with Zach and many faculty from DBMI on the consortium. Even with my best research assistant who work together with the sites, it takes a lot of effort to try to tell them to run the algorithm, send the results back. So we do have to minimize the communication required for this kind of algorithm. So the question we want to answer in a slightly more detail will be the vaccine effect with respect to reducing the risk of COVID hospitalization or death. Here we adjust we treat each of the health system as each of the different source site, and we consider different target site as well. And then we look at patient characteristics, try to capture confounding biases. Here we consider different comorbidities, race, ethnicity, and other factors. And here we, for illustration of the method, we consider Moderna versus Pfizer vaccine, and we compare the COVID hospitalization or death. So we developed a federated adaptive causal estimation, adaptive in the sense that we do allow some of the source sites to have either poor data or so much heterogeneity from my target data that their information is not transferable. We adopt a doubly robust estimation to overcome model misspecification, and we only require sharing of summary level data. Again, for the double robust estimation, I will attribute back to Jamie and many experts in the field to set up the framework. We didn't do anything for any specific source population or target population. Here is just the key step for the algorithm. So we start from the target site. So we assume that by using the target only data, using the doubly robust estimation, we sufficiently adjust for confounder, we can get a valid estimate for the causal treatment effect. Then for each of the source site, we also perform a double robust estimation, but with one more step of projecting to the target data, because I'm not interested in the average causal effect for the source data. I want to project to the target population. So there's one more layer of so-called density ratio to map back to the kind of population that I'm interested in. So the source data also contributed to the estimation of the causal effect for the target population. In the end, we use optimal adaptive aggregation. Here, basically, we use the target data as an anchor, and then we estimate the weight eta k here, which essentially is looking at how different is the target estimate from the source estimate. But we're not doing testing, we're doing an adaptive estimation so that it can quickly figure out whether the source is not very good. For the theoretical development, I want to emphasize that in this particular paper, we actually assume the separation is large enough that we do not have to worry about the post-selection inference. I do have a separate paper with another colleague where we no longer assume that we do account for the potential non-regularity of the inference. But this one, we are assuming basically perfect separation, that your noise from the difference between the source and target is much larger than the variability that we have to account for. So the key properties of the procedure that we attain is that we can ensure non-negative transfer in the sense that I cannot do worse than target only. It's optimally efficient in terms of both statistical efficiency and also communication efficiency. So we only need broadcast from the target estimate and then do once communication with the site. And we establish theoretical guarantees in terms of robustness, normality, and asymptotic relative efficiency. So back to the VA data, this is actually an interesting sort of reality check When I started the project, I actually had a close collaboration with many sites, and quite a few sites are like my very, very close collaborator. After 2 years, I still only have VA data because there are many, many constraints that we are working under. But so today I can still only show you results from the 5 VA regions. We do so because the availability of the vaccine actually is very regional. I actually got my vaccine from VA. I got Moderna and I didn't even have a choice. So we do allow for potential, differences across the health system. And of course, the patient distribution, like the patient cohort also differs by the region. So we treat the 5 regions of the VA as 5 health systems. And most of the uptake of the vaccine, at least for these 2, we only focus on these 2 because vast majority of the VA patient actually received these 2 vaccines. And here I just give you a few examples of comorbidities. And the outcome of interest that I will show you is death after COVID infection within 6 months after COVID, after the first dose of the vaccine. So here, I'm just showing you briefly that the results here, the black one is from our phase estimate, and then the green one is the target only. So you can see that compare ours to the target only, we are substantially more precise. The confidence interval is much, much narrower. The red one is just a naive average across sites. So you don't actually guarantee that the point estimates are close to the site, although the length is similar and sometimes actually even tighter than ours. But overall, compared to target only, we can, on the right-hand side, I just gave you, sort of reduction in standard error. You can see that basically the width of confidence interval is much, much narrower. The remaining time, I want to talk more about data harmonization. So when I started working with the VA, we actually already had some initial algorithm, which was built on top of what Andy Beam had done. I learned a lot from Andy how we can process EHR data to basically generate representations for EHR codes. So we took that simple algorithm and I talked to the VA. I said, hey, I'm going to help you to harmonize your codes based on representations. And then they told me they have 400,000 lab codes. So that's when I kind of just gave up. It's impossible because many of the codes actually have very few observations. So if you have too few observations, you cannot learn what it really means. But nevertheless, for many of the VA local codes, we could try to automatically map them because the manual mapping, it's obviously labor intensive. If you really go through 400,000 lab codes, it's probably very, very time consuming. It really does require domain expert like me as someone who has looked at EHR data for so long. I'll say that's beyond my ability. I cannot understand at all what it means and which codes belong, basically mean the same kind of lab. So that means that basically, require domain expert to harmonize via manual effort is not feasible in general. It's also inaccurate. VA actually does have a so-called OMAP mapping. We actually checked the OMAP mapping ourselves. We asked domain expert. We also use OMAP mapping check ask GPT-4. I would say accuracy is at most 80%. There are many errors. So in other words, not only it's potentially intensive in labor, it's also inaccurate. So our goal is to derive some kind of representation learning so that we can represent EHR codes as semantic embeddings to represent the meaning of the EHR data. If you have embeddings to represent each of the EHR data, then you basically can do the translation across the health system. So here just a sort of graphical representation of the method that's required. So imagine that you have code 1 to N and code 1 to N from the one system, like let's say left is the MGB system, right is the VA system. And then you can learn the representation. You have dictionary. So here, the ones that we show on the graph are the ones that we have dictionary. We know what is mapped to what. And then if you have embedding vector, so it's basically real numbered vector, let's say 500 dimensional from one system, say 500 dimensional from another system. So this becomes a machine learning or regression problem, right? You don't have to use linear regression, but you have data now in front of you. You map the two together. And the first approach we took is that we derived the so-called code embeddings. The postdoc who worked on this project, Xu Shi, she's now assistant professor at Michigan. She actually also collaborated with Andy on the project to learn how to derive embeddings. So from her work, I want to point out two things interesting in her particular work, which I will not dive into the detail, is that the dictionaries can be wrong, right? I mentioned that OMAP mapping itself, at most, is 80% accurate. Can you actually devise a machine learning algorithm that's basically robust to this kind of error? And the second thing that she did, which I think she really did a great job, is that in her method, it also allows us to do not one-to-one. This is so important because in her project, she actually was trying to map ICD-9 to ICD-10. ICD-10 has I think 70,000 maybe, and ICD-9 is more like 10,000. So in terms of magnitude, right, there are a lot more ICD-10 codes. So that means it's not a one-to-one mapping. And I can tell you, I also learned it in a very hard way. The project I mentioned for suicide ideation, because it went from ICD-9 to ICD-10, we actually have a huge problem with ICD-10. There's one code that's very bad. If you use that particular code, it's too basically not specific enough. You include a lot of people who really did not have suicide ideation, but if you exclude that right now, by looking at the incidence of suicide ideation over 2015 and then on from 2016, 17, that's when we start using ICD-10. It actually went basically, our event rate dropped to 50%. That's impossible. Actually, the suicide rate actually has been increasing over time. So that just tells you how important it is to understand how we can map the code. So she developed the algorithm and showed that you can do a lot better compared to state of art at that point. And that was only based on codified data alone, EHR code alone. And the back end, for those who are not familiar with it, for embedding, I just want to mention, we really just borrowed the concept from NLP literature. And sort of historically, there has been a very simple algorithm. Nowadays, probably not many people use Word2Vec. We still really like the algorithm only because it's scalability. And also it gives me good enough of a summary level data that then I can bring back to HMS to run many analyses to integrate across our systems. So from the Word2Vec, just for those who are not familiar with embedding, basically the NLP literature, they look at a context, like look at the sentence, and they look at what are the words occurring around a word like the king, then look at the surrounding word to try to learn the meaning of the word king. Similar in the EHR, if you see one code, we look at over time in a nearby time window on the same patient, what other codes are used. So if you can learn a good embedding here, there famous example is like if you look at the embedding vector of king minus the vector of man plus the vector of woman, it's actually close to the embedding vector of queen. So that means it understands the meaning of king. So we did similarly for EHR codes. Sorry, I already mentioned this basically is what Xu did so far. And we did show that compared to, simple algorithms that Mikolov actually developed just by like ranking cosine similarity, we do a lot better using our algorithm. But if I finish the analysis, I, did the mapping, let's say that I send it to you and say, hey, can you help me to check? Did I do a good job? What would you check? You actually have no idea what these codes mean in the EHR in terms of how physicians use it, right? we are not, practicing medicine for this particular health system. So what we do, if we were given that task to check how we are doing, we're actually looking at a textual description of the code. So that means there's a lot of information that's contained in the description of the code, which we can now leverage a pre-trained language model to represent the meaning of these code using their textual description. We did successfully integrate these so-called incomplete information, from both the text and also the EHR records. And we showed that we can substantially improve the task of code mapping. So here, just to show you our result, our algorithm is the first line MIGI, and the Sapperbird is basically the BERT version that's retrained using the UMLS to learn the similarity, the synonyms, etc. And there are other different versions of BERT, and CODER is another algorithm developed by my colleague. Basically, it's very similar to Sapperbird. And the bottom two algorithm only based on EHR code alone. So you can see that you can substantially improve the accuracy by leveraging the textual string. Here, we did not use any label, so it's completely unsupervised. And basically, we did not tell it this is the task that you need to do. And for lab codes, it's a lot harder now because lab codes, a lot of them have very short strings. They use acronyms that we have no idea what they mean. So you can see without any training, actually, we can achieve much better accuracy compared to other methods, but still not good enough to use. So we did use 500 labels to then fine-tune our model. Then you can reach a reasonable accuracy. For example, top 10 can reach 90%. So at this point, we basically can use this as almost like a smart Google search, right? I enter a code from the VA. I say, hey, find the top 10 codes. Then one of them probably is correct. So then we can basically greatly reduce the manual effort that we need to annotate if we were still going to continue annotation. But annotation itself is hard and takes huge amount of resource. And also, in recent years, so I want to mention Sapperbird and CODER, they not only leveraged textual like BERT, they did leverage the UMS as a relational database. So you can view that as actually a detailed knowledge graph. So graph giving us information about which pair of the nodes have what relationship. So we try to expand our ability to learn or to jointly learn the representation from EHR entities for many health systems. So here, for this particular project, we basically perform so-called a graph alignment of EHR codes. Here, even though aligning multi-institutional code is one of the tasks that we have, ultimately, what we really want is jointly represent them so that we have unified embeddings for EHR across different health systems. So the information that we enter our algorithm, which is basically a knowledge-guided graphical neural network, and the guidance come from hierarchies of the codes, UMLS, and also some of the downstream tasks. But we cannot afford annotation. So I do want to mention that we now are grateful to have GPT. We did ask GPT-4 for the code mapping. So essentially, instead of using human annotation, I use our initial embedding to rank order, like for each of the VA code, for example, I find like what are the potential codes it should be mapped to. Then I ask GPT-4, which one should I use? And we manually checked that accuracy. It's also about 80%. So it's pretty decent compared to the OMAP table that we have. So that this way, I am very grateful to the language model because it skipped the annotation that I need. And that exists in our learning of the graphical neural network. As for those who do use the algorithm, you probably know that the key information that you need, there's a loss function that that we often construct as a contrastive learning, basically, the positive pairs and negative pairs. There's also graph, basically for each of, the target, which of the nodes it's linked with. So that graph comes from existing knowledge graph, and also the code mapping that we do. So the bottom, I just want to show you that by doing so, we can achieve accuracy comparable or slightly better than the supervised MICI that I showed you earlier, and greatly improved upon supervised Sapperbird. And as I mentioned, after all this training, our goal is not just to do code mapping. We want to have representations of the EHR code. Then I can link with many other data. For example, here on the right-hand side, we're trying to predict drug side effect. Here, we just went to FDA website, download the pairs of the drugs and the potential side effects of the drugs. We map to EHR entity, and then we learn the meaning of these drugs. Learn basically from our embedding, we wanted to see whether the drug and the side effect has high cosine similarity. So on the left-hand side, because our algorithm is trained to do a multitask, right? It cannot be so good at detecting side effect, because side effect, I think, is a lot harder to detect compared to indication. So here you can see that without supervision, we do show that by using our graph alignment strategy, we can substantially improve upon compared to the EHR data only or description only. However, on the right-hand side, we use a small amount label to train an algorithm now to aim to actually detect the side effect. We can improve the AUC to 0.85. So that means, with few shot training, basically, you can now use the embedding to learn side effects. So that's sort of a proof of concept to say, after, getting data from multiple institutions through this kind of federated collaborative learning, you can jointly learn a representation, now can go back to the individual EHR data to perform different kind of tasks. So let me conclude by making a remark that, as you have seen here, much of our focus in recent years is actually on the data itself. Our school, including my own department, has a master's of, for example, health data science. But data to me is, a key element of data science. We shouldn't take it for granted. The data just given to us by some other investigators. Now I would say I spend at least 50% of my effort trying to make data quality itself better, less biased, more sort of higher quality in terms of the accuracy. And to me, being able to develop this machine learning algorithm to harmonize data, to me, that itself is science. It's fascinating to me that, if we can work together to improve the quality, to improve the interoperability, I believe that EHR data, especially multi-institutional data, can be much, much more valuable. But of course, we're still limited by data sharing constraint, which we can overcome at least to a certain degree by federated learning. We overcome heterogeneity via this kind of robust collaborative learning. And as I highlighted earlier, it's also super important to harmonize a coding system in order for us to use these codes simultaneously across institutions. That'll be it. Thank you.